Welcome to the EFC webinar on euthanasia and assisted suicide. My name is Karen Siller. I'm an editor with Faith Today magazine. We're joined today by Bruce Clemenger, President of the Evangelical Fellowship of Canada, and Julia Beasley, who is Director of Public Policy for the EFC. And we're joined by you, and we're very glad you're with us. You can send in questions using the chat function on the side of your screen at any time during this webinar. It is most likely that we will save the questions for the last quarter of our time together, but please do send them in whenever you are ready. On February 25th, the Joint Parliamentary Committee on Physician-Assisted Dying presented their recommendations. Their job was to consult Canadians on how to bring in a new law on assisted dying in Canada. They returned with 21 recommendations, many of which are very controversial and troubling to many Canadians. So that's what we're going to be focusing on today. Julia, let's begin with you. Can you please explain to us the timeline and the role of the committee to start with?
Sure. So the new government was given a 6-month extension by the Supreme Court of Canada. So this effectively moved the coming into force date of their ruling from February to June 6th. So the Special Joint Committee on Physician-Assisted Dying was announced by the new government back in December. As you said, their mandate was sort of threefold. They were to review the report of the Federal External Panel, which you may have heard us talk about before. This was appointed by the last government to study the issue of physician-assisted dying. And then this committee was also to consult with Canadians on the issue and to make some recommendations to the government on what the framework of a federal legislative response could be. So their timeline was very, very short. The members were only appointed in the second week of January. They began meeting the following week, and over the course of just over a month, they heard from 61 witnesses, either in person or by video conference, and received upwards of 100 written submissions from individuals and different organizations. And then they held some in-camera meetings. So these are meetings that are not open to the public or to the media. In these meetings, they deliberated what they had heard and decided on what their recommendations would be. So their last meeting was February 18th, and as you said, they issued their report on February 25th. So it was a very, very quick study, a very short process.
Now, I have read some responses to this, and it doesn't feel like anyone is very happy with the committee's recommendations. And I know the EFC has crafted a response. So I guess my question is twofold. Is there anyone who's happy? And how has the EFC responded?
Well, I think many people were surprised at how far they went in the recommendations in terms of envisioning a really expansive regime in terms of dealing with assisted suicide, euthanasia. It wasn't unexpected. Julie and I attended pretty well all the public hearings they had, and from the outset, some of them were already talking about treating the Carter decision not as I think the Supreme Court understood it to be a delicate balance between the sanctity of human life and for a concern for human autonomy, allowing some strict exemptions to the blanket ban of assisted suicide, but they took that as the decision not as a delicate balance, but as a floor. So the question, what's the ceiling? And so a lot of the recommendations go far beyond, I think, what a clear reading of the Carter decision would allow, and it's quite expansive. I think that's what caught a lot of people off guard. Pretty well every group that had Canadian in front of its name, Canadian Medical Association, Palliative Care, Cancer Society, all those major national groups, all of them expressed caution. And realizing that we have a very tight time frame, a lot of the national organizations hasn't had a time to really think through the issue, but also expressed severe caution about making sure we get this right, and making sure that it's not too open-ended, that it is very restrictive, and that there are proper safeguards in place. And that's the concern, is that the thrust of the recommendations is quite an expansive, broad interpretation of the Supreme Court decision.
So are we wrong to assume that based on the recommendations, the government is going to craft something that we're going to be unhappy with? Like, will the government use these recommendations?
We don't know. The concern is that they will, But that's waited to be seen. There was a few other reports. Julia mentioned at the offset there was a federal committee that was struck to look at the issue, and they expressed caution. There's also a provincial territorial group that was established to look at how the provinces might respond, and they, like the Joint Committee, were fairly open and expansive in how they understood the issue to be. So there's a lot of people are advocating for an expansive regime. I think people on the other side that want expansive regime see this as their opportunity to press for something that's open, because they may not get another chance at this for several years. So we're not sure. One issue of concern was that the Liberal government did at one point indicate they were going to whip the vote. Before the legislation had even been tabled, they're going to tell all the MPs that they had to vote for it. They backed off on that. But it seems that they're taking a fairly aggressive stance, so we'll have to wait and see what the legislation looks like.
So Karen, one of last webinar we had talked about how we're not sure that people understand the conversation that was actually taking place up there, and then just to sort of go over some of what the committee has recommended. For one, they would not restrict euthanasia and assisted suicide to people who are at the end of life with a terminal illness, or even to those who have a physical illness. So then they recommend that individuals with a psychiatric condition should be eligible for assisted death, even when there is no physical illness present. They talked about psychological suffering and how this should be recognized as a criterion for assisted death, again, whether or not there is physical illness present. And they also said that individuals who fall into these categories do not need a psychiatric assessment. They suggested that the government does not need to define in legislation what grievous and irremediable mean, saying we can just leave this up to the discretion of doctors. Doctors can make this determination. And this is troubling because the terms, while understood in law to some extent, they're still vague, and there's not in practice any real sort of agreement on what they mean. And also, I think, what a burden to place on individual physicians to have to make those determinations on their own. When it comes to age, they recommend a two-stage implementation process. So initially, assisted death would be made available to individuals 18 years and older, but within 3 years, they want to extend that to mature minors. So these are teens and children who may be, under various provincial laws, allowed to make certain decisions about their health care. So would this then be extended to the kind of decision that children and teenagers can make about their health care, if you call it health care, and so on? Like there's questions of conscience. So the committee agreed with the court that objecting physicians shouldn't have to provide assistance in euthanasia or assisted suicide, but that at a minimum they should have to make an effective referral. And this is problematic for a lot of physicians who may feel that to make a referral is to participate in a course of treatment or action. They also recommend that any institution that receives public funding should be required to provide these services. So again, this will impact faith-based hospitals, long-term care facilities, hospices, and so on, who, you know, operate under a certain ethos and mandate, and to offer these services within their walls would be a violation of these. So there's all kinds of, those are just some of the most troubling off the top.
We've had a couple of questions I'd like to bring in right now because they address something that you mentioned, Julie, about the provincial-federal distinctions here. Pardon me. One person is asking just how the federal and provincial governments work together on this, and another person has asked if the federal law could override a Quebec law, what's happening in Quebec right now legally. So if one of you could address that provincial-federal question, that seems to keep coming up.
I'll begin, and then Julia can add in. Again, in Canada, the assisted suicide, euthanasia are illegal under the auspices of the criminal code, and the criminal code applies nationally across the whole country, and it is within the jurisdiction of the federal government. So when we're looking at creating exemptions to a blanket ban on assisted suicide, which is found in the criminal code, that's very much a federal issue. What Quebec has done previously, and what some of the people are pressing for, is to understand that assisted suicide or euthanasia is a part of medical care. And medical care, of course, is a provincial jurisdiction. So the question is this primarily an issue of criminal code and exemption to criminal code, or is it primarily an issue of medical care? So it's kind of a divided issue. If the federal government, I think it does have the ability to restrict it to a federal issue, so they make sure that it's regulated under the criminal code, and so on. We want to resist the idea that assisted suicide becomes provincial in terms of it's understood to be part of medical care. But there is that duality in Canada, and that's kind of one of the questions for the federal committee, is will they, in their legislation, will they define it strictly as a matter of exemption to criminal code, or will they move down the process of acknowledging or understanding it to be part of medical care, which places it more in the hands of the province. In terms of Quebec, the federal government did not stand up with Quebec. Quebec passed legislation which asserted its jurisdiction over the issue, and the federal government did not act aggressively to protect its jurisdiction in terms of criminal code, and so it looks like the federal government doesn't have the stomach to do that as aggressively as they could have.
Julia, do you have anything to add there?
I was just trying to look through my notes what one of the constitutional experts said in terms of what some of the dividing lines were between what the federal and the provincial can do. He was, it gets a little, when we talk about consent, competency, those sorts of assessments probably trickle a little more down into provincial jurisdiction. But what this particular expert did make very clear was that the court required the establishment of safeguards around whatever they do. And so he felt that in whatever the federal government did with their legislation, they needed to build in those safeguards, which, determine things like age, eligibility, those kinds of things. So it does get a little bit murky, but as Bruce said, because we are talking about an exemption to the criminal code, the federal government does have that responsibility.
And if the federal government does not clearly define the safeguards, the definitions, and so on, then what happens is it's up to each province to determine that on their own. And then you're going to end up with a patchwork quilt. So some provinces will be more permissive than others. Some provinces may not choose to legislate. They'll leave it to doctors to decide. Others will develop more complex regimes. So if the government's going to legislate and allow assisted suicide to take place, then we think the federal government needs to be very clear and envision and construct as strict safeguards as possible that are nationally applied.
I'd like to, as a mother, I guess, I responded most strongly to the mental health recommendations, and also the mature minors, that someone who was potentially, if I was reading it correctly, depressed and going through a terrible time could actually be allowed to access physician-assisted death in our country. And then this idea of mature minors was just, it felt like we were leaping forward years into the future of what we thought could go wrong. So I'm wondering if we can drill down a little bit further into those two. I'm sure other people reacted to other parts, but those were the ones that really grabbed me and people I spoke with.
Yeah. The mental health question, I think that was one of the most upsetting days for me in the committee. I think the day they heard from, I think it might have been the Canadian Association for Mental Health, was actually on Bell Let's Talk Day. So here we were on this day where the entire nation is sort of coming together and telling people who are struggling with depression and mental health not to give up. There is help, there is hope, life is worth living. And at the same time, I was sitting in the hearings listening to some of the committee members actually challenging the cautions that they were hearing from the mental health professionals, who were saying, you need to be very, very, very careful if you're thinking of allowing this kind of thing for patients with mental illness. But what they were pushing was this idea that psychiatric patients should have the same rights as everyone else. But the professionals were very, very clear with their cautions. They talked about how it's just not that simple. Mental illnesses affect thinking. they can impair your insight and judgment. So the head of the Canadian Psychiatric Association talked about how symptoms of clinical depression, for example, include things like negative expectations of the future, a loss of hope, a loss of expectation for improvement, even when improvement may well be possible. There's a loss of future-oriented thought, a tendency to focus on the negative and minimize or ignore the positive. All of these things, you know, the sense of identity is distorted. Feelings of helplessness and hopelessness and so on. And so what they were saying was, when we're talking about people seeking physician-assisted death, we are talking about the most extreme cases. So while those things may not be in play in every patient, certainly when we're talking about the ones who were severely affected enough to be seeking assistance, they probably are. One of the things he said that I thought was really powerful, he said, we think with our brains, not with our hearts or with our limbs. So they were recommending that when a person with a psychiatric illness presents themselves to a physician and is asking for assistance in death, that there be multiple assessments carried out over time by individuals who are properly qualified to make these kinds of determinations. So what sorts of distortions is the patient experiencing, and how are those distortions affecting decision making and so on? How do we address any other psychosocial factors? So they were so clear in the committee that we need to be so very careful when it comes to this, you know, patients experience these kinds of illnesses. But yet the committee recommended access should be made available to them without psychiatric assessment. And then you mentioned the age, and I think when you put those two things together, the picture becomes really frightening, because you know, how many young people struggle with depression or with anxiety, or, you know, imagine a football player who suffers a traumatic injury and feels like, you know, this is it for me. I was a football player and now I'm not, and where is my identity now? So it becomes very, very troubling. And you know, there are reasons we have the laws in place we do when it comes to minors and the sorts of things that they can do, the kinds of decisions they can make, to vote, to drive a car, to drink alcohol. And it's hard to think of a decision that is of greater consequence than the decision to have your life ended. So it's really troubling.
Well, it seems we put so much energy and resources and passion appropriately into suicide prevention, especially for young people. And then on the other hand, we may be offering it as a health option. It just seems so hard to understand how we've come to this.
Yeah.
Well, that's why in this, you know, the federal-provincial mix, there is a strong push to understand assisted suicide. They call it assisted death. So they want, so the others, many want to place assisted suicide and euthanasia in the context of palliative care in terms of a spectrum of end-of-life care options. But then it then makes the whole health system complicit, and it makes it bivocal. So at one point we're developing national campaigns and provincial strategies to address particularly suicide amongst young people, saying no, no, no. There's options. There's you know, let's talk. And at the same time, we're looking at setting up a system whereby, you know, assisted suicide, euthanasia will be part of of what we provide in terms of basic health care across Canada. And so that's the concern. That's why if we're going to go down this road, we want to keep it as federal and keep it as focused on the criminal code and a few minor exemptions to the criminal code in specific circumstances, and not broaden the conversation to see this as part of a broad range of healthcare, because it conflicts the healthcare community. It'll affect doctors, it'll affect nurses, it'll affect you know, palliative care wards, it'll affect extended care facilities, if this is seen to be part and parcel. And again, the public message is that now the government says, okay, a suicide is okay in certain circumstances. And I don't think we can. That's very dangerous for society to be that divided in the message you're sending to all its people.
Can we address the question of institutions being required to offer it as a service, potentially, like Catholic hospitals, for example, or other hospitals or centers that is not part of their ethos and they don't want to offer it? What's happening with that?
Well, again, what the committee has recommended, and because the issue was before them, but they've decided that what they recommended was that if a institution receives any type of government funding, that it should be forced to comply. Again, the idea here is that they see assisted suicide, euthanasia, as part of medical care. And so any place that offers medical care must also offer assisted suicide, euthanasia. And so, of course, this it's not just Catholic, it's Salvation Army. There's a number of evangelical denominations have extended care facilities. There's a number of, I was talking to someone, there's a new hospice being opened up in Chatham. It's kind of a multi-faith effort to develop a hospice care. And if there's any government money involved, are they going to be compelled to allow assisted suicide on their premises? So it goes to the heart of what the nature of the institutions are, but also the heart of what it means to care for someone who's dying. And it's interesting. One group appeared before the committee, and they really didn't like the idea of assisted death because they thought when they care for people who are dying, and they're completely opposed to euthanasia, assisted suicide, when they're caring for people who are dying, that's how they're assisting people in their death. And so they said, please use the word hastening death. Don't talk about assisted death, because assisted death is a good thing. It's palliative care. It's an interdisciplinary thing. It's how we care for people who are nearing the end of their life. But don't confuse that and don't conflate that with hastening death, taking a positive act to kill someone. And so that creates a dilemma, severe dilemma for faith-based organizations who are providing end-of-life care and believe strongly in the sanctity of human life, believe strongly in caring for the vulnerable, believe strongly in engaging and kind of walking with people through the shadow of the valley of death. By treating this as just another part of the medical spectrum, then will again compromise, I think, hospitals, our healthcare system, medical profession, and so on.
So are you saying that if an institution receives federal funding, the idea is they will have to comply with whatever the law is? Is that our expectation?
Well, I don't think it was just federal funding. It was any type of government funding. And so there's municipal, there's provincial. I mean, it's a lot of extended care facilities that may be faith-based, do receive provincial funding for nursing care, for example. And so that was the recommendation. We'll see what the federal government does. But again, there's been some strong voices being expressing concern. I mean, one of the trite things, what was so frustrating when we were sitting in the committee hearings, is one senator particularly kept saying, well, bricks and mortar don't have values, right? And so in other words, he's reducing institutions to bricks and mortar and says, well, they don't have freedom of conscience, freedom of religion, they don't have ethics, they don't have sentiments, they don't have feelings. Well, of course, that's a silly argument, because institutions are created by people, with certain convictions, certain ethos, certain approach to how we're going to handle life. And this will go to the very heart and core of what it means for some of those institutions to continue to exist.
One participant has asked, why is this happening so quickly? Why this rush, it feels like, in creating a law that it doesn't feel like people are going to be happy with?
Well, some of that is imposed a little bit by the Supreme Court decision. They had already given a 1-year sort of suspension of their declaration for the government to respond, and there was an election in there, and it just nothing really happened until after the election. And so then they already had to they only got a 6-month extension. So there's sort of this deadline imposed by the court to the extent that their declaration will come into effect if there is no legislation passed by June 6th. So that doesn't mean they can't enact legislation after the deadline. It just means that there would be kind of this void where things could happen and not be legislated or regulated. So the rush is to make sure there is something in place before that deadline passes. The problem with that, of course, is that it is such a huge issue. It's a major shift in healthcare, in our criminal law, all kinds of things, and arguably the consultation, the national conversation has not really happened on it. But that's where the short timeline came from. Like I said, it's not like they couldn't legislate after the deadline. It's just that if they fail to do something, then there's this void created
I think also, I mean, it's a good question because uh, more broadly, the government can, they could invoke the notwithstanding clause to delay the application of the Supreme Court's decision. They have the power to buy themselves more time to address the issue. It's, you know, they don't need, the notwithstanding clause isn't only used to kind of forestall something that's inevitable. You know, you could use Section 33 of the notwithstanding clause, basically, which means notwithstanding what the Supreme Court has decided, we're going to continue on and proceed the way we are proceeding. So the government has a mechanism to actually buy itself more time. And also, historically, I think up to 2010 and before, there was many times private members' bills, parliamentary committees, Senate, House, have looked at the issue, and every time they've consistently said no. Mm-hmm. So in a sense, what's happened, the Supreme Court has kind of opened the door and has set a time frame, and everyone's now accelerating to meet the time frame. And also, we know in the context, a majority of Canadians are sympathetic to the idea of assisted suicide in narrow situations. I don't think they've picked up on how expansive the committee's recommendations are. So there's general kind of public sympathy for the idea. And the government's, and I think anyway, many MPs are feeling kind of, now's the moment, we need to push this through, we need to move this quickly. And what's happening, the conversations aren't happening. So back to the issue of age. Supreme Court said competent adult, and the committee is recommending, again, in 3 years we expand that to minors. A number of groups, in speaking to the issue of age, urged caution and said we need to think about this. We need time. And in a sense, the committee heard them because they have this two-stage implementation, but they've still decided that after 3 years we're going to consider involve minors. And so they've kind of precluded the conversation. And whereas a number of advocacy organizations that deal with minors, deal with juveniles, we're pressing, saying this is kind of uncharted territory. We need time to think about this. We need time to assess it. We need to have this full conversation. That's my concern, is that as a nation, we're not really having a full, open conversation about what the implications of this are, what the meaning is, how this will unfold, how this will impact various systems. And so those who are in favor are pressing hard to try to accelerate the conversation to move as far as possible. And there's so far there's not enough, I think, resistance to that, or at least that resistance that's there is not being heard and felt at the federal level.
The Canadian Medical Association has responded strongly and said some doctors are actually, you know, maybe a minority, I'm sure, but thinking of leaving the profession over this. Are you aware of any doctors or associations who may challenge it legally based on the issue of freedom of conscience? That's a question from a participant. Is that even possible to do? And just if you could speak to us on the issue of freedom of conscience, how will we see that played out, do you think?
There's actually already a legal challenge in place. The College of Physicians and Surgeons of Ontario recently put out a policy which would require doctors who conscientiously object to assisted suicide euthanasia. But actually, in the context, they were looking at issues like abortion and abortion pills and prescriptions and so on. They actually made the decision that they're going to require doctors who are conscientiously opposed to provide effective referrals, which is kind of, in a sense, writing a prescription for the medical procedure or the prescription, or in emergency situations to provide the service themselves. And so and that's been challenged by a group of doctors, evangelicals and Catholics in Ontario. So there's already a lawsuit challenging the College of Physicians and Surgeons of Ontario decision. Saskatchewan made a parallel decision. So there's already legal action that started there. And again, what the Joint Committee did is they extended that to their recommendation to the federal government, that again, doctors may not be compelled themselves to provide assisted suicide or perform euthanasia, but they should be required to provide an effective referral. So even though some colleges across the country don't require an effective referral, the federal government made that recommendation. So there are a number of groups. One of our affiliates at EFC is the Christian Medical Dental Society, and they've developed a network with other groups like Catholic Health Association, the Archdiocese of Toronto, other organizations that are involved in providing health care. And they are raising the issue of conscience quite actively in this debate, as are we. But again, there is already a legal challenge, and if the government passes legislation to require effective referral, I'm sure that legal challenge will be extended to what the government's done. This is critical, because for a lot of doctors, it extends to nurses, extends to any type of healthcare professional who's involved. If you're, by your reason of conscience or your faith, are deeply and completely opposed to assisted suicide euthanasia, are you going to be compelled to participate in the provision of consensual killing, basically? And so some are, I know law students are now looking at, is this a profession they want to go into? If they're going to be compelled, what area of medicine can you practice which would insulate you from being compelled? So it's going to the heart of what it means to provide medical care, and of course it strikes at the heart of the Hippocratic Oath. The whole history of the Hippocratic Oath came to play because death was becoming too easy in Greek society. When a doctor came to, if a doctor came to visit you, you didn't know whether that doctor was there to kill you or to care for you. And so a group of doctors signed the Hippocratic Oath saying that they will do no harm. So you knew as a patient, if a doctor attended you and they had signed the Hippocratic Oath that they weren't going to kill you, they're actually going to care for you. And so, compelling doctors to violate that goes to the heart of what it means for them as healthcare professionals. As I said, it extends to nurses. The Ontario Nursing Association just released its guidelines in terms of dealing with nurses until the legislation's passed. So it's a huge, huge issue. And again, it affects the conscience of medical people, anyone involved in healthcare, in caring for people who are dying, and it extends now to also the threat to faith-based institutions that provide care.
Yeah. One of our participants has mentioned that in Quebec, their understanding is that the Quebec Code requires only the institution to refer. The doctor can let the institution know that he or she cannot refer. I don't know if that really makes a difference, but is that your understanding of what it's like in Quebec?
Yeah, they have, it's kind of it's an indirect referral. So okay. There's like a middle, so there have been different suggestions. There were different suggestions made to the committee about how that could be accommodated. Is there a third party? Is there a self-referral service? Those kinds of things. Back to the doctors just for a second. When they appeared before the committee, the CMA said that about 30% of their membership would be willing to participate in assisted dying. That number actually decreased sort of the more you expanded the parameters around it. But roughly 70% of their membership had indicated they were unwilling to provide assistance. And of that 70%, they said this, a small percentage indicated that to make a referral would be a violation of their conscience or beliefs. But the CMA was really firm on this point. They said that even though it was a small percentage of their membership, the rest of them, the whole rest of their body, would stand firmly behind them and would fight for their right to not have to participate even indirectly in assisted death. Back in January, kind of in the middle of all of this, I saw my own doctor. He's been my doctor since I was, 10, 11, 12 maybe. And while I was there, I mentioned to him that I had been attending all of these hearings and following the issue very closely. I sort of told him some of the conversation that was happening, and we had a really sort of deep conversation, and it was really heartbreaking to see how upset he was by this. In fact, I don't think I've ever seen him quite so animated in all the years that I have been seeing this doctor. And he said, why are they forcing this on us? We don't want any part of this. And if there is anything in my entire career that has ever made me think it's time to get out, this is it. And he's not alone. The CMA says about 70% are unwilling. They don't want any part of hastening their patients' deaths. But this conversation has become so focused. Even the committee title, the report of the committee report, the title of the report was Medical Assistance in Dying, a Patient-Centered Approach. So that kind of tells you, there's all of the focus is on the patient, the autonomy of the patient, the right of the patient, which is not a bad thing, except that what about the autonomy of the physicians, of the pharmacists, of the nurses, of all the medical professionals who are implicated in this? So it's a really tricky question, and we're hopeful that maybe the government is going to take some steps to protect conscience.
Well, another participant has asked, we talked about this a little bit already, but to what degree we anticipate the government will go by the committee's recommendations. So the reality is we don't know, right?
No idea.
So it feels like now is the time for action. I know the EFC has been urging people to interact with their MPs and so on. Tell us what we should be doing. And in churches specifically, and someone has asked this, what can pastors and church leaders be doing? How can they be presenting this in their congregations?
I'll start. We actually had a EFC constituent send us an email a while ago. They had contacted their MP, sent a really great email outlining their concerns with euthanasia and assisted suicide and saying, what are you going to do about this? And forwarded us the reply they got back. And in that reply, the MP's office said, we're honestly surprised we haven't heard more from constituents on this issue. So get involved. We've been posting all kinds of resources on the website saying it is a critical time to be engaging with your MP. They are in Ottawa to represent your concerns. They care what their constituents think, but they need to know. They need to hear it. So this is a really important time for people to be sending letters, making phone calls, even better, try and visit in person. It doesn't have to be a complicated letter or conversation. It's just, listen, I'm following what's happening in the media. I hear what the committee are recommending, and I am very, very concerned about the direction this may be going. How will you represent my concerns? So there are a lot of resources on our website to sort of help people understand, the kinds of things to say. Here's a sample letter. Here's how to find your MP and how to get in touch with them. So it's really important now, even because soon we're expecting reasonably within the next few weeks. Parliament resumes on April 11th. So I think it's fair to think that given the June 6th deadline, that there's a good chance that very soon after that they will be tabling legislation. So MPs are going to be in a position of having to consider it, having to debate it, and eventually having to vote on it. And it's all a very short timeline, so they need to hear these kinds of concerns from their constituents.
I think a second thing, we do have a declaration that we released in October. It was signed by, I think, 57 church and other faith leaders on euthanasia-assisted suicide, and expresses deep concern and opposition to assisted suicide euthanasia. It talks about conscience. It also talks about the importance of palliative care, and we've opened that up for for anyone to sign, and it's available at the website euthanasiadeclaration.ca. And I think we're over 22,000 signatures so far. And so that will help us. But also, when you read through the declaration, you'll get a good sense of the issue. And it's a good basis upon which to say to your MP and say, here's a declaration I've signed. This lays out my concerns. So it helps you give language. But also, something that we've done, and it's right behind Julia, if you show a book that we developed. And what we've done is Faith Today over the last 18 months or so has written a number of major articles dealing with caring for people who are dying, euthanasia, dealing with being vulnerable as a senior, and we've compiled that. And at the end of each of the articles that we've drawn from Faith Today, there's a series of questions that are great for a personal use, but also for a small group study. And so I think we need to have the conversation. We need to think through carefully what we're engaged with here. And then, as Julia said, consider signing the declaration. Get your people in your church to sign it. Talk about it amongst your friends, your neighbors, people in your church, and again, connect with your MP. Again, this issue, though it was brewing during the election, didn't really become an election issue, and so we're not sure where a lot of MPs stand on the issue. And again, MPs have a variety of different levels of expertise and a variety of different issues, but your MP may or may not be fully briefed on the issue, and so now is the time to engage with them and bring the arguments to bear and ask them, like Julia said, how are you going to represent me on this issue?
And we do have like letter writing guides, I believe, and you can request that euthanasia and palliative care discussion booklet at the efc.ca. You can email us at efc@theefc.ca also to request any of those resources or ask any questions about how to engage effectively or how to bring the discussion to your church. So that's really good to know. I feel convicted because I haven't contacted my MP yet, and I'm going to do it this afternoon, actually, when I get home, because it does seem like such a strategic time, and the fact that the Liberals have said that they're going to allow their MPs to vote freely on this issue just opens the door even more, right, to actually have them be representative of their constituents, perhaps.
And the Liberals backed off on their decision to whip the vote. We're not sure whether they may do that at a later date, but certainly the NDP and the Conservatives are going to allow a free vote amongst their MPs. So it's time to have the national conversation. It's time to engage in the issue, and to raise it in various contexts. And we need to think carefully as a church how we're going to respond.
One participant asked a question that I think is really important in terms of what if we do end up with a very permissive law, one that we're not happy with, but we remain the Christian community, we remain, churches caring for the vulnerable within our own communities. So how can church leaders be caring and equipping their own congregations to resist that and to I guess really deeply and compassionately care for the vulnerable among them?
I can think of two tracks. One would be to continue to press the government to monitor carefully whatever safeguards are in place. Are they actually effective? We're pessimistic about the effectiveness of any safeguard given the experience in Europe or other jurisdictions that allow assisted suicide. But again, even when the legislation is passed, there's always possibilities of amending and tightening it up if we see abuse and if our concerns are realized. So the political pressure need not end. I think the other side of it is, again, the issue of palliative care, and whatever the law allows does not deter us from providing the kind of care that we feel it's important for us as believers to give. Again, our animation in this issue comes from our belief in the sanctity of human life, and our belief that all life is of immeasurable worth, that our neighbors are loved by God as are we, and we are to love our neighbors as ourselves. And so I think it requires us even to double our efforts in in engaging with those who are in the shadow of death. They're going to need more care than ever if we end up with a really permissive regime. And so I think it'll be a challenge back to the church to say, if we really believe about the sanctity of human life, if we really believe about caring for the vulnerable, how are we expressing that in practical and real ways in our communities, in our provinces, in our nation?
Yeah.
Thank you. We're going to, I want to bring up the provincial-federal connection again as we come to a close, because another person has asked a question about that, so it seems to really be on a lot of minds, that how we can encourage the federal and provincial governments to work together to protect the vulnerable. That keeps coming up, so I don't know if you have a final word on that.
I think, an MPP is there in the same capacity as an MP. So we tend to function mostly at the federal level, but absolutely, whatever the federal government does, the provinces will respond one way or another. Either it will be comprehensive and they'll have to comply, or they will not be, and they will be coming up with their own sorts of regulations and decisions about how the practices occur, where, and those kinds of details. So absolutely, you can use the same kinds of principles and communications to speak to the provincial government as well, because they will be part of whatever scenario we end up with at the end of the day. So that's a good point. Yeah.
Okay. Great. Well, thank you everyone for joining us. We're really glad that you were able to tap into this resource. Thank you, Bruce and Julia. The EFC will continue to keep you updated on this issue and provide resources. Again, you can find all of that at the efc.ca. You can email us at efc@theefc.ca to request that discussion guide or any other resources. Please do contact your MPs and get active on this issue. Now is the time. You can find this webinar archived at the efc.ca/webinar, and that address will be up on a screen in a moment if it's not already. And you can also access previous webinars we've done on this issue as well. Please spread it around, send the link to your friends and colleagues so we can all work together on this. Our next webinar is on April 20th with Brian Stiller, who's the World Evangelical Alliance Global Ambassador, and we will be talking about evangelicalism around the world and hearing from him. You can visit faithtoday.ca/subscribe to find out how you can get his latest book along with Faith Today. And again, thank you for joining us today on this very important topic, and we'll see you next time.